Nile TV, lighting up the region.
Hello and good morning, dear viewers. You're most welcome to the DAKTARI show, and this is a health educative show which airs here on West Nile TV every Thursday from 10 a.m. to 11 a.m. where we bring you experts in the medical field, we bring you doctors, we bring you radiotherapists, we bring you radiologists who come and educate you on healthy concerns, healthy matters regarding your lifestyle and on how to improve and keep yourself safe from getting certain complications due to disease illnesses. And of recent, we have seen people in the community, it be the children, the immunocompromised, like getting difficulties in breathing, they get those challenges, some end up even losing their lives. So today we have an expert, Dr. Morgan, who is going to take us through some respiratory diseases like tuberculosis and pneumonia. You're most welcome to the DAKTARI show, Dr. Morgan. You can introduce yourself to the viewers.
Thank you very much for West Nile TV for this initiative. My name is Dr. Eddie Morgan. I've been working with Rema Medical Group. I think I started working with them since 2020. And yes, I have served the community of West Nile since I think my beginning. I started my internship from Arua Regional Referral Hospital, and yes, now I'm here with Rema Medical Group. You're all most welcome for this interactive show.
Okay.
Yes.
We are indeed grateful, Doctor, to give in your time to come and educate the viewers of West Nile TV. You know you are a man of busy schedule, so we don't take this for granted. We are indeed grateful. So maybe let's pick on our topic of discussion. What are like just roughly an overview, what are respiratory distress diseases?
Thank you very much. When we are talking about the respiratory distress diseases, as you framed it, we talk about these diseases that affect the respiratory system. Yes, there are quite many, of which TB happens to be one of them, but there are quite many respiratory diseases.
Okay, thank you, Doctor. So now let's pick on with TB, that is tuberculosis.
Okay, so when we talk about tuberculosis, we simply define TB as an infection which is caused by the Mycobacterium tuberculosis complex. What do you mean by the Mycobacterium tuberculosis complex? It's an infection caused by very many species, I could say, of Mycobacterium. We have what we call the Mycobacterium tuberculosis. We have Mycobacterium africanum, we have Mycobacterium bovis, we have Mycobacterium microti. So that complex is what is responsible for the infection of not only the lungs but also other parts of the body. So if we can say maybe talk about the classes of TB, we can categorize them as pulmonary TB. So this one actually affects the lungs, but we also have the extrapulmonary TB. These ones affect other parts of the body. We see TB affecting the bones, we see TB affecting the heart, we see TB affecting the abdomen, we see TB affecting the kidneys, Yes, so when we talk about TB, it has it affects almost most organs, but the common one which we are going to deal with is, I think, the one that is affecting the lungs. Yes, so what are these symptoms that a community needs to be aware of outside there? When you talk about TB, especially the one affecting the lungs, which you call the pulmonary TB, so that TB, patients, we normally see patients presenting with signs of cough. If you're having cough greater than 2 weeks, that is if you're a healthy person. For those who have HIV, we can assume any cough they present with, we suspect TB. So we have, if you're having cough more than 2 weeks, that should raise an alarm. If you're having night sweats, drenching night sweats, especially in the evenings, that should also send you an alarm. If you've been having evening fevers for more than a month, say every evening you're having fever, that also should raise an alarm. Then those who have lost weight, progressive loss of weight, if you've lost approximately 10% of your body weight, that also should raise an alarm. So those are some of the clinical features when we are talking about TB. Okay. Yes, thank you.
Okay, thank you very much, Doctor, for that definition of what TB. Hope our dear viewers have got to know what TB is or tuberculosis is, and also how it presents. So now, Doctor, maybe a viewer may be asking, which things can I do to put me at risk to acquire this TB?
Yes, so when you talk about the risk factors for you to acquire TB, remember you should know how the TB is spread. TB is spread through droplet inhalation. If you inhale the droplets containing the TB, definitely you will get the infection. How do we inhale? If we're in a confined space and I'm talking, you can get TB. If I cough, you can get TB. Laughing, these are some of the things that produce the droplets. So the droplets move through the air and you inhale them. That is how it gets into your system, especially the pulmonary TB. But we also have other sources, for example, for M. bovis, which is spread through taking unpasteurized milk. Yes, so you can also acquire that one TB, that is now other forms of TB. So what are those risk factors that you do that makes you susceptible to TB? One, if you're immunocompromised, and what are the things that makes your immunity go down? If you're having things like if you're having diseases like HIV, you're having cancer, we know cancer tends to derange the cell lines, especially those ones that help us fight. If you're on chemotherapy, those cancer patients who are taking chemotherapy, we can see them also, their immunity go down. If you're malnourished, we see malnutrition, especially in the refugee settlement, of which West Nile happens to be one of them. So if you're malnourished, definitely that is also a risk factor for you to get TB. Yes, so those are the risk factors. Definitely, if you're exposed to someone having TB, that is also sends a high alarm. That is why we actually do contact tracing for individuals who have TB. We tend to screen the person presenting with the symptoms. We presumpт them. Then we go ahead and do, if they have been confirmed bacteriologically, then we go ahead and look for those close contacts, what we call contact tracing. Yes, thank you.
All right, thank you, Doctor. The way you have talked about the spread and the risk factors of getting TB, it's presenting almost like COVID.
Yes, almost.
Okay, almost. Yes. Yeah.
The only difference is they have different causative agents. The other one is a virus. This is more the bacteria.
Okay.
Yes.
So now, maybe in your presentation, I had this immunocompromised, where you gave the example of patients who have HIV, the malnourished. If you may be asking, what does immunocompromisation mean?
Yes, immunocompromisation simply means if you're having something in you which is affecting your ability to fight. So what are those things that makes your body fight? Definitely you should be having proper nutrition to give your cells the right nutrients they need, so that you can be able to make those white blood cells and other cell lines which are very vital to help the body fight off the disease. So everyone has, at least everyone has a risk factor. That is why we go ahead and immunize you with the BCG vaccine, which is supposed to prevent you. But that does not mean it's supposed to prevent you and help your body to fight off. Our bodies are constantly being engaging these pathogens on a day-to-day basis. It's only if they are overwhelmed that is when now you start seeing these symptoms. But don't be shocked if you and I both have TB.
Oh.
Yes. But because of our strong immunities, it hasn't yet come outside.
So it means that someone can have the TB but without those clinical presentations you talked of.
Yes, it is very true.
Okay, doctor. So now, doctor, you have taken us through the presentation and the causes. So, and say a viewer may be asking himself, he has been at home, he has noticed that he has had cough for more than 2 weeks. They are weak, they are getting the fatigue, they are having those night sweats. What can they do immediately in the community before rushing to the hospital as a home management? Then they come to the hospital for medical and approved management.
Yes, home management, definitely to viewers, I think the most important thing is to note if someone is having severe forms of TB or they're having severe forms of infection, because you can have co-infections. So if you manage what is presenting, if the fever is very high, we do things like tepid sponging, but I would advise them to get to the nearest health center as soon as possible. So I would advise them to go to the nearest hospital, and I would advise community there to be vigilant. If you see your neighbor, you see your child has been having cough for a very long time, we advise them to come, and we do that. Because cough alone has other causes. We have things like allergies, that people are having allergic asthma. So someone might think they're having cough. There are also things like foreign bodies. For example, if a child ingests a foreign body, you can have a hair strand in the lungs that makes the child cough continuously. And sometimes we even go ahead and treat them clinically. But later on, if you get a history, you'll find out that this patient, so you do an imaging, you find out that you might be able to locate the foreign body, and which would be the trigger of the cough. So we advise them to come and seek medical intervention as soon as possible. Yes. And making matters worse for TB, we are really aggressive on TB, and I would advise our listeners, those signs and symptoms were pointed out. If you've been coughing for more than 2 weeks, if you've lost weight, if you have drenching night sweats, if you're having difficulties in breathing, yes, so those are alarming signs for TB. So you should seek medical intervention as soon as possible.
Okay.
Yes.
All right. Thank you very much, doctor. What I've noted key from that presentation, I've said, as long as a viewer gets those presentations, immediately they should come to the hospital for management.
Yes.
Without even a wait.
Yes.
Okay. So now, doctor, can you also take us through, like, this patient comes to the hospital, how do you always manage these TB patients?
Yes, so when the TB patients come to the hospital, we normally first start by triaging them. We have to identify who are those who are actively coughing, so that we isolate them. We want to prevent them from spreading
To the others.
to others. Yes, that is why if it is a more isolated place, we identify them, we take them to the coughing centers or the coughing area, then we do tests. So the simple tests that we can do in most of these laboratories is the microscopy. We ask for the sputum smear. We look for what we call the acid alcohol fast bacteria. What we call the acid fast bacteria. So we do the ZM test on them, then we detect, the lab people are trained to detect that. When we detect that, that should be good enough in resource limited settings. But we normally advocate when they come, we get their sputum. One on spot, you cough, you give it to me, I test. One, I'll give a bottle you, that early morning sputum, before you brush, before you do anything, you cough it out, collect it, then we do what we call a gene expert. The reason for doing a gene expert, we want to be able to detect the TB and also find out, is it resistant? We have the MDR, multi-drug resistant TB, which is also actually a burden to the community. So that one is actually even worse. If you've got the multi-drug resistant TB, then the extreme multi-drug resistant TB. So those are the things that we will find that the cost of treating one multi-drug TB patient is really very expensive to the doctor. So we do that. We also request for TB LAM, especially if you're immunocompromised and your CD4 count is below a certain level. So the specialist can request for your urine TB LAM, which we can use. But you have to be HIV positive, your CD4 count has to be below a certain value. That is when we request for it, because it is not really specific and accurate enough. Then we have introduced one for the children, where now we do the stool. We advise now to do the stool. I think it's a new thing. I'm not yet acquainted with it very well, but we do the stool. It is actually helping us detect TB. We actually detected one multi-drug resistant TB in a child. So we are using their stool. No longer now, because children, if you cannot tell a child to cough and produce the sputum. So I think we have upgraded to that modality. So those are some of the modalities. Then we have the imaging. I can request for an X-ray to see the lungs. So that one I can, if I see those lesions, miliary TB, you find a miliary picture like millet kind of appearance on the X-ray film. Or you find cavitation, or you find the lymph nodes with what we call the hilar lymphadenopathy. You find those the lymph nodes around the hilar area tend to enlarge. So we use that, the imaging sector, to also detect, and we can make a diagnosis based on the imaging. So for others, for example, extrapulmonary TB, we can, if it's in the lymph nodes, we can request for those aspirates. We send them to the labs. For the TB of the spine, we can get also those bone samples, then we also test them. Or we also do X-ray of the spine. Sometimes the spine patients are having what we call a gibbous. So some portion of around the spinal cord tends to bulge outside. So that also should send a message. Yes, so then we also do abdominal ultrasound scan. We might get TB. Then if the patient is having ascites, also we go ahead and subject the ascitic full fluid to TB examination, so that we can be able to detect and treat accordingly. Yes.
So now, doctor, you have taken us through how you diagnose or to confirm that someone has TB.
Yes.
Suppose you confirm someone is positive for this mycobacterium responsible for the TB. You recommend to them, how do you say, multi-medicines?
Multi-drug resistant TB, the MDR.
Okay. So, those medications, how often do these people take these drugs? Or for how long do they take these drugs?
Yes, after us confirming, because the confirmation can either be clinically, I can confirm it clinically, as the doctor makes that judgment, let's treat this patient clinically. even if the tests come out to be negative, because sometimes these tests can miss out. So after that confirmation, definitely now we shall send them to the treatment area unit. So in the treatment, we normally have, we start with the initial phase, say the intensive phase, where we give 4 types of antibiotics. I think we have rifampicin, we have pyrazinamide, we have isoniazid, and ethambutol. So we start that intensive phase with that, though we have also some adjuvants we give, say maybe vitamin B6, sometimes we give some other medicines, normally supplement depending on how the patient is presenting. Sometimes we put them on steroids. Yes, that now is for the doctor to make that change. So we start with that intensive phase for 2 months. And it also depends on the type of TB we get. 2 months is for pulmonary. We give you that 2 months with the 4, then we reduce them to 2 antibiotics for more 4 months. So a total duration of 6 months, and you have to be compliant with the medications. So I advise my patients there who are taking those medications to be compliant. If they get any side effects, they should come and report it to us so that we can see how we can either change or supplement. So it's a total of 6 months treatment on those regimes. Now, if you're having TB meningitis, that can go longer to even 12, 10 months. If you're having TB of the bone, it normally goes longer. So for those who start with in the intensive phase, then you have the continuation phase. Those are the 2 phases. So those ones tend to go longer depending on your presentation. So there are those who have the multi-drug resistant. Definitely we shall put them to the second lines. Yes, then there are those who have extreme. There now we use the injectables and other modalities, which are quite costly to the government. So the cost of treating one TB patient is really too much. If we left it to the public, if we do it on private basis, you really feel the pinch. So we advise patients to really follow their treatment, get the treatment on time, finish, and they come back for tests. Even when we are treating them, we normally monitor them because we want to discover. We monitor after the end of the 2 months, you come and do the test. We see, is it still positive? Is the sputum still positive? If it's still positive, it tells us something. Even the 5th month, we again do certain follow-up tests to still see if we test and the sputum is positive, then we know that maybe you're resistant to these first-line medications. You get it? Or if we test and it has cleared, then maybe you've cured the TB. So that is how we normally treat it.
Alright, thank you very much, Doctor. Indeed, hope our viewers have gotten to note that these TB medications, you take them for 6 months. Indeed, Doctor, that one is worrying almost. Okay, let me...
Yeah, it is a burden.
It is a burden.
If you get patients who don't adhere to that, and that is why even during the treatment, sometimes we may require you to constantly follow up. And so now we're using the VHTs. You can have a partner. Most times we advise health workers to do what we call a direct observed therapy. I give you the medicine, you swallow. Because we see patients are quite stubborn outside there.
Yeah, they may just take and sleep over the...
I know us as the African population, as long as we have taken for 1 month and we feel the symptoms have gone away, we feel we are much better. And yet knowing that when you stop, you may be just making this mycobacteria more and more resistant. And now the other drugs that we might put you might even have more and more worse side effects. You get it? So it is better you get it, you sacrifice, you take the treatment, and you'll be fine.
You'll be a honest patient.
Yes.
Alright, thank you very much, Doctor. So now you have taken us through this management of TB. Like suppose an individual you can give it in a summary. An individual fails to go to the hospital for management of this TB, like gets the signs and remains locked at home. Are there some complications this individual may develop?
Yes, first and foremost, depending on where the TB is affecting. If it's the lungs, you might have problems with breathing. Yes, difficulty in breathing, you get into respiratory distress and
You may
you
die.
get asphyxiated and die. Yes. Two, you can have it spreading to other parts of the body. You can start from the lung, then to spread to other parts, including the skin. Yes. So three, you can have what we call meningitis, TB meningitis. These are some of the complications. You start vomiting, lose consciousness, and you can also die because of that. Pericarditis affects the heart, causes fluids in the heart, restricts the heart from pumping, and you also die because of the heart failure. We have peritonitis. You can have infection in the abdomen. It causes perisilent abdomen is one of the features of peritonitis. So you get intestinal obstruction and get those features which can also predispose you to that. The other complication, of course, now it is your productivity, and depending on the area it affects might be really impaired.
So now, doctor, you have taken us through how TB is life-worrying, how it presents, the medication, how it takes too long, 6 months, other times we say 10, actually even 12 months.
Yes.
So in the community, how can we prevent or keep ourselves safe from acquiring this TB?
Yes, prevention starts from birth. When you're born, the government goes ahead and gives you a vaccine. So we advise mothers to take their children for those vaccinations because it's one of the things that helps us prevent the TB. Two, you have to identify those who are actively coughing, need to be isolated, need to seek treatment as early as possible so that you don't spread to others. You get it? To children are very susceptible, especially if they're below 5 years of age. They can easily contract the TB. Yes, 2 years is even actually worse. Yes, so they can easily get the TB. So that's why when they come, you ask them, is there any person having TB at home? If they say yes, then you can suspect. We tell them that is now a presumptive case of TB, what we used to call a TB suspect. Those days, yes. So vaccination, at least for those who are infected and are not on treatment, you put on a mask. Mask, things like social distance, washing hands. Yes.
Like as if you are preventing COVID.
Exactly. Almost all that model, the COVID model, will really apply also to TB. The good news is with TB, if it's in an open area, they rarely survive the sunlight. So sunlight really kills most of the TB. So most people get them if they're in a confined place. For example, the prisons, schools, the nursery, kids, yes. Those places where there is confined. I think even the video halls where people go and watch entertainment and they're screaming, yelling, yes. So these are some of. So you prevent, you put on a mask, hand washing.
Cough in the elbow.
Yes, make sure you cough in your elbow, you get a handkerchief and you cough there so that you don't transmit those droplets and others inhale. That is how they acquire the first information. Then also we advise you to check and know your HIV status, which is very important. There are people out there who do not know even the last check, I think 2, 3, 5 years ago. Only to start coughing, and later you find that you're positive, which even complicates the management of TB. Yes, so we advise those, if you're positive, they will start you on treatment. But that will be now done by the expert, because there are those who are positive At the same time, again, they're having TB and in the active form. So most times we manage them, we have a different protocol of managing them. We don't just start them on HIV treatment. I think we first tackle the other one, then we come back to.
Okay, yes. Thank you very much, Doctor. As almost we are coming to the closure of the first episode, can you give a reason as to why I've seen these TB, treatment centers are always isolated? If it's in the hospital, you find them, they have a specific place which could be far away from other patients. Is it maybe because of the transmission?
Yes, it's because of transmission. You remember, patients who are inside and they're sick, they are immunocompromised. So most of those patients who are inside the hospitals, there is an element of an immunity compromise. So if someone is actively coughing and you're having multi-drug resistant TB. Okay, so I was saying those who are in those, that is why we isolate those patients in the wards, because we do not want them to spread the infection. Only when we initiate them into treatment, I think for the first 1-2 months, that is when they cannot actively transmit the infection. But also that one is subjected after we have tested that we actually don't have. So we intend to confine them because we don't want them to spread infection. Yes.
Okay, thank you very much, Doctor, and also our viewers who are viewing this educative show here on West Nile TV. Let's first get into a short commercial break and shall be back in the next segment where Dr. Morgan will take us through pneumonia. Thank you very much. Let's get back.
West Nile TV, lighting up the region.
Brand new Global Star TV with StarTimes Inside Technology. New TV innovation with an inbuilt decoder that connects you to both StarTimes antenna and satellite signal. With StarTimes Inside Global Star TV, you can enjoy over 300 local and international channels, 1 month StarTimes highest bouquet for free, automatic system update, more benefits, more affordable. StarTimes Inside Global Star TV is available in all StarTimes branches and dealers countrywide. StarTimes Inside, entertainment inbuilt.
We are the passion you've been waiting for! Yunus Junior Santamo! It's our league, our football, our boys, our style. StarTimes UPL new season starts 15th September. Go for it! What a finish from Ashraf Bukume! The Ugandan flair, Brazilian samba, Portuguese magic, the night football craze. More TV games live on Senyuka Prime and Fufa TV only on StarTimes.
The StarTimes UPL, our league, go for it.
West Nile TV, lighting up the region.
We'll be back, dear viewers, from that short commercial break, and still the Daktari Show, which is a health educative show which airs on National TV every Thursday from 10 a.m. to 11 a.m. With us today we have Dr. Morgan, who works with Rema Hospital, and in the first segment he took us through TB, what it is, its presentation, the management, and also the prevention. So in this next segment he's going to take us through pneumonia. We'll be back from that short commercial break, Doctor.
Thank you.
Yes. Okay, we can pick on what's pneumonia.
Yes, thank you very much, and thank you to West Nile TV and the audience at large. I'm going to talk about pneumonia. We keep listening to this term pneumonia.
Okay.
We go to the hospital, the doctor says your child has pneumonia. And you wonder, what is this thing called pneumonia? So pneumonia simply means an acute infection or inflammation of the lung parenchyma or the lung alveoli, to be more specific, yes. So if you're having that infection and inflammation of the lung alveoli, so it is what we define as a pneumonia. And we have, I think we have two major types of pneumonia. We have what we call the bronchopneumonia. These ones affect the lung parenchyma and the bronchi. Then we have the lobar pneumonia. These ones affect a certain segment. You know, our lungs have segments, especially the right lung has like 3. So you tend to, the pneumonia might affect one portion of the lobe, of the lung lobe. So if it is the lower one, if it's the middle one, the upper one, so we define that as a lobar pneumonia. Yes. So what are the causes of pneumonia? We have the microorganisms which range from the bacteria, the viruses, the protozoa, and the fungi. Yes, which actually give us this pneumonia. So to be more specific, every age group has different organisms that are more susceptible to. For example, the bacteria, we see in neonates. Neonates, we are seeing mostly the strep species. We are seeing I think Staph aureus, E. coli, chlamydia. Those are some of the organisms that mainly affect neonates. Those are between the age of 0 to at least 28 days. Then children from 2 to 12 months, we also see things like Haemophilus influenza. We still the strep aureus, Klebsiella. Yes, so we can see. Then also for the older people, we have also things like Mycoplasma pneumoniae. We still see Staph aureus, Streptococcus pneumoniae, Haemophilus influenza. These are all bacteria that can cause pneumonia depending on the age group. For viruses, we see the respiratory syncytial virus. We are seeing the influenza viruses. Children also measles does affect the lungs. Then we see things like COVID-19, which is the coronaviruses, which also do affect us. When we come to the protozoa, we are seeing those who are immunocompromised. They're having infections like pneumocystis jirovecii, which normally comes in for those who have immunocompromised, especially those who are having HIV. Yes. Parasites, we have things like the worms. We have seen things like the hookworms, the strongyloids. Yes, which also sometimes do affect our lungs. Thank you.
All right. Thank you very much, Doctor. You have taken us through these causes, but I had you like say, my child. Are you trying like to mean this pneumonia is more often common in children?
The age groups, we call that most of the risk factors. Of course, if you're of young age, we tend to see them getting more of the pneumonia. Those who are ill, the elderly, those who are above 65, 60 years and above. So we see them, they have the risk, an increased risk of contracting a pneumonia, which can either be a community acquired or a hospital acquired. You can acquire it while in the hospital. Yes. So, and also if you're immunocompromised, if you're having, say maybe you can be having malnutrition, you can easily get a pneumonia, HIV, cancer, yes, leukemia. Those are some of the things that can make your immunity compromise and predispose you to getting a pneumonia.
Okay, thank you, doctor. So you have taken us through, actually, you have given
I actually even forgot the fungi.
the fungi.
Yes, sometimes you can have fungal infections which can also affect the pneumonia. Yes.
Okay. So now maybe, doctor, like you have already given some of the risk factors or which things which can predispose someone to get this pneumonia.
Yes.
There are also other factors, it be environmental.
Yes, environment also sometimes plays a role. For example, there are those who are in the, let me say, cold, or those there are pneumonia associated with the AC, the use of AC, what you call Legionella pneumonia. So if you come to me and you're working in an office kind of setting, or you're in a swimming pool, fast waterfalls, and you contract a pneumonia-like symptom, then I might be thinking about Legionella pneumonia, whose management is also a bit different. Yes.
Okay. So maybe, doctor, how do these patients who have pneumonia present with
presentation? Of course, for babies, you can have things like fever. Babies have a temperature, cough, chest pain. I'm giving them now general. Chest pain. Then we have cough with or without sputum. The sputum can be purulent, like with some pus. So you can present with that. We also see things like loss of appetite, headache, difficulty in breathing. So the signs of difficulty in breathing in children, you see them. The respiratory rate, the symptoms, the respiratory rate is normally high. For neonates, it should be greater than 60 breaths per minute. For those aged between 2 to 12 months, around 50 breaths per minute. For those aged between 1 year to 5 years, around 40 breaths per minute. And for those adults, anything greater than 30 breaths per minute, we know that now there is distress. Then we see your oxygen percentage, oxygen saturation, what we call the SpO2, will be low, less than 90. Anything less than 90, definitely we know that there is already a compromise in the lungs. We see the children, they start grunting, the nose becomes big, what we call nasal flaring.
They want to take in more air.
Yes, you see that nose opening and what we call the nasal flaring. Then we have chest indrawing. As they're breathing, you see the chest is going downwards. Then we also carry intercostal recession. So those are signs that a clinician can detect when you present. Yes. Then we can go ahead and auscultate. We use our stethoscope to listen to the lungs. Sometimes you can get either the bilateral crepitations, bronchi, or you can even hear a wheeze. Yes. So those are some of the signs and symptoms that present in patients having pneumonia. So for those older than 65, physicians normally use what we call the CAB 65 risk factor. If you're greater than 65 of age, then other parameters there. So we normally do that. Thank you.
All right, thank you very much, Doctor. Indeed, it's an exciting discussion. Also, hope our viewers are enjoying it. Yeah. So now, Doctor, you have taken us through the presentation. Are there some home remedies someone can do to like relieve these symptoms before they come to the hospital for medical management?
Yes. The mothers can do that. For example, things like for babies, if the temperature is high, yes, you can give paracetamol, then you do tepid sponging before you come to the hospital, because if you don't do that, the child can go through what we call febrile convulsions. Convulsions due to the increase in temperature. Temperatures above 39 degrees Celsius. So you can see these children starting to convulse because of that. So better you do the tepid sponging, you give paracetamol. Yes, then you ensure that the child's clothes are not that tight. Then you come to the hospital. Very fast, you run to the hospital, especially when there is difficulty in breathing. Yes.
Okay. Thank you, Doctor. So now, like a mother has done that at home, but the child had that difficulty in breathing, you said they should run very fast.
Yes.
And the mother maybe, these mothers always run fast to you. How always do you manage these people?
Yes, when they come to us, of course we do the emergency. We first do what we call the ABCD. We have to secure the airway. If there are secretions, we remove them. We ensure that there is proper circulation. The breathing is okay. So when you do that, then you request, we also do the vitals there and then. Take the respiratory rate, take the SpO2. If the oxygen is below 90, you don't wait. You do not send the child to the laboratory to go and do tests. You take care of that immediately. So you can put the child on oxygen. Yes, then you can also take those other parameters, because you have to know the child could have been, the sugar levels are low. So you do the RBS, because breathing and what is a process that consumes a lot of energy. And sometimes you find these kids die because of hypoglycemia. So you have to do that, to take the RBS. If the glucose is low, you correct immediately. Then now you tackle the big thing. What is causing? You can do a CBC, you can take the aspartame, you can do a blood culture. Of course, those, if you have money, those who can afford, we advise them, you can do a blood culture, or you can do those aspirates in developed countries. They can take the aspirates, then they test and identify the specific organism, then they tailor the treatment and target that organisms. Nowadays, we also encourage people to do what we call culture and sensitivity, because there is a lot of resistance outside there. Now, because for us, we treat on a blanket, we know it's an infection, but we don't know which specific infection. So that's why sometimes we give our broad spectrum antibiotics. Then we think, let me cater for the mycoplasma species. Or let me cater for the staph species by adding maybe a cloxacillin in it. Or let me cater for Legionella by giving ampicillin in it. So you see, we normally do that, we predict. But in more developed settings where they have everything, they can actually identify the organism, then they tailor the treatment. So we shall do for you a complete blood count. We see the cells, if they're elevated. If lymphocytes are elevated, then it might point towards a viral. If both of them are elevated, the lymphocytes, the granulocytes, the neutrophils, it might point through a mixed kind of infection. So we shall also know how to deal with that. Then if there is not that, sometimes it can be asthma. So we shall also run our few tests. We detect if the child is not improving, we can decide to nebulize the child and see if they improve. Yes. So after doing that, the CBC, we do the RBS. If we need to do the chest X-ray, we can order for it to identify if it's a lobar pneumonia. Of course, you have to listen to the chest of the child to see. Yes. Then those other investigations, as I told you.
Okay.
Yeah, which way?
All right. Thank you very much, Doctor. You have taken us through the management. So also, in case an individual in the community, maybe a mother, is reluctant on taking the child to the hospital for management of pneumonia, can this child also get complications?
Yes, complications include the child can fail to breathe. And you know, when you get asphyxiated, you definitely will lose your life. Yes, those are some of the complications I've seen developing in pneumonia. So that is the ultimate prize. If you don't seek medical attention, chances are high that the child might go toward the other direction, which we want to try and prevent. Yes. Other complications, of course, we can see the infection spread all over the body, get what we call sepsis, and they go into septic shock, which later on results to death. Yes, so sometimes also we can find severe inflammation in the lungs, which can cause fibrosis, then also restrict the lungs from performing well, so the child will have that problem with breathing. Yes.
Okay, thank you very much, Doctor. So
on the other aspect of management, of course, we use antibiotics. We have our choices. Every clinician has their choice, but most times we follow the protocols. Every organism that causes pneumonia, we do, including COVID-19, which causes. Sometimes we do, for the viral infections, we do supportive care, those things. Manage the fever using paracetamol, give antibiotics. So we use mainly azithromycin or sometimes amoxicillin. Yes, then we give the cough syrups to suppress the cough. We may add salbutamol if there is difficulty, or if we hear a wheeze. Yes, we may give you salbutamol and maybe nebulize and discharge them inhaler. For asthmatics, we do that for them. If the child has a history of asthma, definitely we use the asthma protocols of management in these patients. Yes. So after we have managed them, they will improve. Children are fighters; they normally improve. We only have problems with the adults. It is hard for them to improve. So we have to give very strong antibiotics sometimes. But I advise clinicians out there to really rely on culture and sensitivity in the management of our patients, because we are seeing lots of resistance, including here in West Nile. Yes, thank you.
All right, thank you very much, Doctor. Indeed, it's an exciting discussion. So how can we prevent this pneumonia in the community?
Pneumonia, like I said, the government has gone ahead to arrest some. Through immunization, we give that the pneumococcal vaccine. Yes, I think also, of course, for things like cough, we follow the protocols. Wash our hands, which is the first bullet. Washing our hands, ensuring that the immunity of the children. Okay, we check, we treat those who are HIV positive. We start them on medications. Malnourished children, we send them to those units so that they get proper treatment, and we try and improve our immunity. So a good immunity helps you fight better, like that. But I think the vaccination has really seen a significant decrease in the pneumonia cases, especially in the children in Uganda. Yes, so that has also lowered down the mortality rate. Yes, so, and of course, early treatment. Detect early, treat early, better outcomes.
All right.
Yes.
Thank you.
Then also, parents should adhere to the medicines they are given to. If we tell you strictly 5 days, please complete the 5 days. If the child is not improving, please run back to we see these cases where people are taking children to the traditional healers and what, and by the time they come to us, it's almost too late. Yes. So that is that.
Alright, thank you very much, Doctor. Actually, me what I noted most, I said these children are fighters. So if you manage them well, they will be high chances they'll pick up and they will get well.
Yes.
Actually, that is the most important thing I noted out. So hope our viewers there, if you get any child who has signs of pneumonia, rush the child to the hospital. They manage him. The child will improve definitely. So now, doctors, we're almost coming to the conclusion of the program. I have seen these presentations done for TB and pneumonia. They're almost the same. So like in the community, how can someone know, maybe I could be having TB? How can I differentiate TB from pneumonia?
From pneumonia?
Yes.
TB is more of a chronic, especially if we're talking about pulmonary TB of the lungs, because it's all in a lung kind of present infection. We know in TB, those other things that I talked about have to come into play. If you've been coughing for more than 2 weeks, there is weight loss, been having evening fevers for more than a month, you're having drenching night sweats, you get it. Those are all signs that point towards TB. For pneumonia, of course, TB can also worsen and give you signs resembling pneumonia. You can also have TB inducing the pneumonia itself. Yes. So the pneumonia is all these other signs I've been talking about. Your respiratory rate goes up. You have difficulty in breathing.
The
fevers that are more than 38 degrees and above. Yes. So almost all those signs. So for TB, it's classical and it's normally chronic after a long time. Pneumonia is more of acute kind of presentation. Yes. So they are almost, I could say, the same, but they're different in terms of the duration and presentation. The other one is more of a chronic kind of thing, though it can be acute. And the symptoms can worsen. While pneumonia is an acute, it happens 1 to 3 days, you're having worsening of symptoms. So that is how people can easily differentiate them. True.
Alright, thank you very much, Doctor, for giving in your time, and also our viewers who have been with us from the start of the show, as almost have come to the end of the show. Today we had Dr. Morgan, who took her through an exciting topic of discussion. He took her through TB, what TB is. He took her through pneumonia. Indeed, Doctor, we are grateful for giving in your time to come and educate the viewers and masses of West Nile TV. Maybe you can also give in your conclusion remarks as we are closing up the show.
Thank you very much. My conclusion remark would be, I would advise the community and the mothers to be vigilant. Especially the women are very, very vigilant when it comes to health. Yes, these signs and symptoms that we have discussed, you take note of them. If you're having patients or people who are coughing for a very long time, we advise you to take them to the nearest health center so that we can test for TB. West Nile is still on a hot spot. So we have to curb this TB and prevent the further spread of TB. Yes, so if we do that, I think we shall see progress and we shall achieve our target of eliminating TB in Uganda. Yes, thank you very much.
Alright, thank you very much, Dr. Morgan, also for giving in your time and expertise and also the facility. We are also grateful, and also our viewers who are with us from the start of the show up to the end of the show. We are grateful. Till we meet again next Thursday from 10 a.m. to 11 a.m. with more exciting other topics for you. I have been your host, Sandy Junior Tom, with Elliot, the producer. Thank you very much. Till we meet again.